Welcome everyone. Thank you for joining today's Adert first session. So Adert stands for איכות חיים דרך רפואה פליאטיבית לא אונקולוגית, and it's a new community of practice we started in order to promote non-malignant palliative care in Israel. It is meant to be a supportive professional community for discussion and shared learning. So bear with us. Here with me is Dr. Daphne Grossman, and we've been working together with Dr. Adir Shulov and Shirley Yanai and Gidon Lifshitz on starting this community of practice. So Daphne is our booby. She's a palliative care physician from North York General Hospital in Toronto, Canada. She's also an associate professor in Department of Family and Community Medicine in University of Toronto. I'm Asya. I'm an internist from Asut Ashdod and currently midway through my fellowship in palliative care in Mount Sinai Hospital in Toronto. Our focus today is palliative care and respirology, an area where symptom management, psychosocial support, and interprofessional collaboration are super essential. And we're very fortunate to have two outstanding speakers with us today in this Israeli-Canadian collaboration. So first I'll introduce Dr. Rebecca Colman. She is a respirologist at Sinai Health System in the Toronto Lung Transplant Program at University Health Network. She's also a palliative care physician at Sinai Health System in Toronto, Canada. Also assistant professor in Division of Respirology and Palliative Medicine, University of Toronto, and also has Master of Sciences. So that wasn't enough. And our very own speaker is Dr. Shirley Yanai, and she's staff physician in the palliative care unit and director of the supportive care clinic in the Pulmonary Institute and the ALS clinic at Rabin Medical Center of Belinsson campus. She's also head of palliative care services for the Tel-Aviv-Yefo district in Kללית Health Services. So thank you both of you. Thank you for being here. And with that, I'll hand over to Dr. Янай to begin our case presentation.
Thank you, Asya, and thank you for becoming a dream come true. And it's really something that we and Adir and Gidon thought about it, and you make it possible with Daphne and everybody over there in Canada. So thank you. So we're gonna to present a case, a real case, a patient of mine that I'm already, if it's 2026 gonna be, so I'm treating this patient for 4 years. First time he was presented to me, he was 60 years old male on 2021. He was divorced and father of 3 children. Currently, back there in 2021, he was in a relationship and he lived by himself in a private 3 floors house. He was a self-employed עצמאי that used to travel a lot in the world. 2/3 of his years he traveled around the world. And as you can see, all the stuff that I wrote it because everything that his person is influenced by his disease. Okay, so his past medical history at 87 from work accident, he lost his vision in his left eye. So like he said to me, he knows what trauma looks like. He had hyperlipidemia, he had hypertension, osteoporosis before he was treated with steroid for his lung disease. He had Barrett's disease in the esophagus, which was very important for us when we treat his symptoms. And he was former smoker, so he quit smoking 30 a lot of years ago, and he had just 5 pack years, but he quit smoking when he was 32. So his lung disease started in 2019. His primary presenting symptoms was cough, and he was diagnosed with hypersensitive pneumonitis based by cryobiopsy of his lungs. Then afterward, so like I said, his symptoms was cough, very annoying cough, mainly at night, interfere with his sleeping. Rarely happen at the daytime, so he still can kept his job. The thing that was interfering with his job is dyspnea, which was very mild, but he was very active person. So it started bothering him when he had very significant exercise. And actually in 2021, when I met him at first, it's like the sickness of the lung was going beside him, not influence a lot of his condition, and his palliative performance scales was 70, similar to Kornofsky, like we use. So if we investigate more his condition of his pulmonary, you can see that the FEV1 to FVC was not that worse. It was 85. And after 6 minutes work, the situation was 86. So he didn't need oxygen when he was in rest. But when he was in exercise, very hard exercise, he was hypoxemic. And it was in the CT scan, we saw that the condition is progressing compared to the 2020, but it was progressing slowly. Upstream, so the medication that he took was, his pulmonologist started with him with 30 milligrams of prednisone that we will talk about it later, but didn't help too much to the cough. So he went down to 10 milligrams. He took Risprim 3 times a day, prevention and prevention of azanil. He started with 2 kind of antifibrotic medication, which was Ofev, nintedanib, and Cellcept. And he had Lipitor, Cardiloc, Lecapress, Promenix, and Nexium. When we were going to hear the last, we will see that his Lecapress became this drug. Prior to that, he was on tritase with ACE inhibitor. So continued on 2000 and jumping to 2025. He's now 70 years old. He lost 15 kilograms in his last 2 years. Is now hypoxic in moderate effort, is functional lung decline, and he has now in 6 minutes walk the situation going down to 77, and his pulmonologist work up him to be listed in lung transplantation. And he still have the symptoms of cough, but now his shortness of breath was much more emphasized in even mild to moderate exercise. Like when he go to remove the grass in his house, it was very, very hard for him right now, and he need to have oxygens with him. It will start his anorexia period of time because it's loss of his appetite, and now is not in a relationship, and he have also hard without of the loneliness, and his palliative performance scale was 50. So he's not in the hospice level. He's still a transplant official candidate. And how do we manage the symptoms, and how do we integrate the palliative, the supportive care? So now we'll ask Rebecca to help us in this case.
Thank you, Shirley. So there's a lot of things that have come up in this case, and we're going to try to tackle a number of them, obviously not all of them. So we'll talk about symptom management, and we'll focus specifically on his cough and his dyspnea, which were his predominant symptoms. I'm not going to touch on the loneliness. We're going to talk a little bit about managing side effects of antifibrotics, which are quite common, especially when patients are taking nintedanib. We're gonna talk about more of a philosophy of integrating palliative care for patients with non-malignant lung disease, and the specific transplant-related considerations. My slides are no longer, there we go. So cough, I think is probably one of the hardest things there is to manage in palliative medicine, I find, and especially in non-malignant lung disease. So I always go back to first principles. So as a respirologist, I have the ability to also test for things like asthma or reactive airways disease, which may improve with inhalers, and then also to stop people from using bronchodilators and inhalers who don't need them, and maybe it's actually contributing to the cough if they don't actually have reactive airways disease. Thinking about things like postnasal drip or upper airway cough syndrome, reflux. As you mentioned, this patient had Barrett's esophagus. And ACE inhibitors, and he was on an ACE inhibitor, though I think that was changed. There is evidence in the management of cough for neuromodulators. That's mostly in the idiopathic cough setting, as many people may be familiar with. So the gabapentin, pregabalin, or some of the tricyclic antidepressants. To be honest, I find that it's not always that effective, and that many people start having side effects and a lot of sedation before they actually get good benefit, though for the people it works for, they're great. Multimodal speech pathology therapy is a combination of cough suppression techniques, vocal cord hygiene, and cough education, and it sort of targets this idea that, cough begets cough, and if you can teach people about cough and how to suppress their own cough, you may reduce the frequency and the severity, and also this idea that often cough, even if someone's got fibrotic lung disease, it's often multifactorial, and we just got to clean their vocal cords and make sure that we're sort of really managing all different parts that might be contributing. Antitussives, so things like, and apologies if the names in Israel are different, but things like dextromethorphan, I find don't work, and the evidence is quite poor. They're still listed. If someone really derives great benefit, sure, they stay on it, but otherwise, again, many of these people, as you saw, are already on so many different medications, and reducing their pill burden or their syrup burden may help. And then the expectorants, things like wafenicin or other ones, the evidence is extremely poor for their efficacy. Corticosteroids, so there is a role in fibrotic or interstitial lung disease for low dose steroids. Higher dose, this gentleman had hypersensitivity pneumonitis, so may benefit from steroids for a flare or something, but higher dose steroids in most fibrotic lung diseases are really kind of shunned at this point because we know about all the bad side effects of steroids, but there may be, some patients do improve a little bit with low dose. There are studies that show that thalidomide is actually effective in treating IPF, idiopathic pulmonary fibrosis related cough, though at least in Canada, you can't really get it because it causes birth defects. Inhaled lidocaine can be used to really as like almost an abortive, or just to give people temporary relief of their cough, which then may translate into more sustained relief. And I have a slide on this in a few slides. If you sort of stop the vicious cycle, they can calm down their cough. They may cough less later on. And then really opioids, I find, are the mainstay of treatment for cough in most areas, but specifically in fibrotic lung disease. And there's a lot of newer data that supports this, finally. So these are the results figures from 2 recent trials. I think people in the interstitial lung disease world are potentially familiar with. The first on the left is the nalbuphine trial that was published in the New England Journal of Medicine in the spring of 2023. And then on the right is the Pacify Cough trial that was published in the Lancet Respiratory Medicine later in 2024. And both of these, I think, are sort of, well, they're not practice changing, because as a palliative care doctor, we were already giving people opioids, but I think that they really sort of provide evidence for what we were doing. So both were randomized, double-blind, placebo-controlled crossover trials. Both used escalating doses or doses of opioids. The nalbuphine trial, I increased the doses, like doubled it every 5 days. Nalbuphine is a mixed opioid agonist and antagonist, and they used it to try to prevent any of the, opioid-related side effects that they might experience, like respiratory depression. In the Pacify Cough trial, they just used sustained-release morphine. So nothing fancy. And the truth is that nalbuphine oral is not actually available in most of the world. We certainly don't have it in Canada. But both trials, you can see, showed significant improvements in daytime cough frequency. They used objective cough counters. They wore a monitor on their chest, which picked up sound and vibration frequency. And so, again, both very positive trials with significant benefit over placebo. My slide arrows are going left to right instead of right to left as I'm used to. So I have to go the wrong way. So importantly, I think a lot of people are concerned about safety and tolerability of these opioids. And both studies did show that in the treatment group, there were more adverse events. And in the nalbuphine study, 9 out of 42 had discontinued and only 1 out of 43 in the morphine study. But importantly, neither study showed death or respiratory depression. The most common side effect was constipation in both studies. But essentially they were safe. And I think the nalbuphine study, they got to huge doses, which is really important. Doses that I probably wouldn't even touch in my practice. Unfortunately, there was no impact on breathlessness, and that was a secondary endpoint. So I said I'd talk about inhaled lidocaine. So it's not that commonly used, but perhaps it should be used more. I mean, it's probably a bit harder to administer. So as many may know, it's a sodium channel blocker and inhibits neuronal excitability in sensory nerves. And so these sort of proximal cough receptors can be mitigated or can be silenced a little bit by them. And as respirologists or pulmonologists, we use this before bronchoscopy to just try to reduce the cough before we bronch patients. And so you get rapid cough alleviation. Again, cough begets cough. So when we cough more, our receptors, our neurons are more excitable. And if we can just dumb that down a little bit, it's like sort of a little bit of relief of an itch, and then you stop scratching and then you get less itchy. Then we can hopefully, have sustained relief. There are side effects, so it does cause oropharyngeal numbness. There's a bitter taste. It can cause bronchoconstriction, so you have to be careful. And some patients can experience a transient increase in their cough just after. You can mitigate that by using a mouthpiece, which is what we usually use before a bronchoscopy, though maybe harder to get at home instead of a face mask. And you can rinse your mouth after exposure. And then you usually have to also warn patients, same as after they were to get a bronchoscopy, that they shouldn't eat and drink for a good few hours after until their gag returns. Otherwise, they're going to aspirate. I think that's probably the biggest danger. All right, we're going to move on to dyspnea. So dyspnea is a really common symptom experienced with patients with fibrotic lung disease. I don't know how well, I think the colors are funny on this slide. I didn't make it, but essentially same thing. We always want to treat the underlying cause. We want to rule out other contributors like anemia or heart disease. And then pulmonary rehabilitation, it's, I think, standard of practice in anyone who's listed for lung transplant or being assessed for lung transplant, but in all patients, exercise is a really important part of managing fatigue and shortness of breath if they can do it. Trials of FAN. In this trial, the authors actually suggest systemic low-dose opioids before a trial of oxygen, even if they're hypoxemic. I've put arrows because I would always try to optimize or maximize someone's oxygen before starting them on opioids. And the opioid data for dyspnea is actually quite disappointing. I mean, we use it, and I'll talk about that, but the top figure is the Kronberg-White trial from 2020. The bottom figure is the Mabel study that we were all anxiously waiting for, which was just published a few months ago. And really, if you try to look for evidence to support use of opioids in dyspnea, it's going to be very hard to find. I will tell you that I think that the trials are probably not the same as the patients we're seeing. And in many of the trials, they don't necessarily prescribe opioids in the way that I do and many of my colleagues do. I'm sure Daphna as well in Toronto. So many of them will use sustained release opioids. We're often using short acting opioids. A lot of trials used standing doses of opioids. And while I used to do that to try to make sure patients took their medications and counter fears of addiction and things like that or dependence, I actually find it doesn't work, and then your people are taking more opioids than they need. So I'm often using it sort of preemptively before exercise. Most of the patients on the transplant list in Toronto do use opioids before they go to their physiotherapy and rehabilitation sessions, and it actually helps them get through their sessions and achieve what they need to achieve from an exercise perspective. The good news is that despite the lack of efficacy in these trials, really none of them have showed that they were dangerous. And so I've just listed a whole host of them from over a decade that show that when these are used and titrated carefully and safely, we are not seeing increased episodes of respiratory depression, and we are not seeing increased mortality. So antifibrotic side effects are very common. I work in tandem, so I will manage symptoms in my own patients, but most of my end-stage lung disease practice are sent to me from different respirologists, and then I co-manage with the interstitial lung disease clinic at the University Health Network and with the airways clinic at Sinai Health, and again, University Health Network. But so I think pirfenidone, nintedanib, hopefully nerandomilast when it becomes available, will not have such significant side effects, but I think we still expect some. But so one thing is we tell patients to take the medication with food. They can take 5. So diarrhea is a really common side effect with all of them, but mostly with the nintedanib. So trials of fiber, things like Metamucil, they already get prescriptions for antidiarrheal, so they're using them. And then some of them experience some nausea. So I will use metoclopramide, even though it's a motility agent. Daphne and I were talking about this earlier. I don't find it increases diarrhea that much in my patients, but certainly 5-HT3 receptor antagonists like ondansetron can be used, or some of the other anti-nauseants. The other part of my practice is to advocate for dose reductions for patients. So I think so many patients feel so married and so dependent on their antifibrotic, and without it they think that their disease course may accelerate, but if their weight loss and their diarrhea and their nausea are ruining their lives, then a dose reduction or a drug holiday or discontinuing therapy, especially in someone who's on a transplant list. I don't know what the wait times are like in Israel. They're variable in Toronto, but may actually be what's better. And if someone's going to potentially be delisted from transplant because their BMI is falling below their, our cutoff and what's safe to then go ahead with a transplant, then it's a really important risk-benefit discussion. And often, people may be too afraid to bring that up with their respirologist. And again, I would never do this on my own. This is always in consultation with either the transplant team or the patient's own respirologist. Oh, I went backwards again. Sorry. All right. So moving on to palliative care in non-malignant lung disease. So I think most of us who work in this field recognize that and one of the reasons for this talk, and I think this whole community of practice, is that in many of these non-malignant diseases, there really is this unmet need from a symptom burden perspective, both physical and psychological. And what I've shown you here are graphs and tables from studies that really look at the main end-stage lung disease. I've not included ALS here, but these are the lung diseases that progress to transplant. And then on the bottom is CLAD, for those of you who are unfamiliar with that acronym. That's chronic lung allograft dysfunction. So that's the destruction and the breakdown of lungs that happens after transplant. So COPD is in the middle. This is a figure from the New England Journal from 2015, and it just shows you the range of diseases. So it's not just cough and shortness of breath, though those are the two we dealt with here, but patients have a lot of different symptoms. Same with pulmonary hypertension. Again, the list is so long, it's almost hard to read. Interstitial lung disease. Again, yes, dyspnea is experienced by up to 90% of patients and cough 94%. But look at GI symptoms, look at depression, like things are, anxiety, really common, spectrum of illness, cystic fibrosis, huge burden, plus the burden of treatment. And then again, chronic lung allograft dysfunction. So this is just a plug for palliative care and palliative care integration, both before and after transplant, because these, unfortunately, transplant patients do run into trouble later on as well. I went backwards again. All right. So this is recognized. So palliative care integration in these non-malignant diseases, in non-malignant lung disease, has been shown to improve patient symptom and quality of life. It improves patient and caregiver satisfaction. It leads to increased goal concordant care. And it's also associated with reduced healthcare utilization and spending. And because of all these benefits, so the ISHLT, as the International Society of Heart and Lung Transplant, has really pushed over the past 5 years to try to better integrate palliative care in their patient population and in their practices. And then there's a current guideline that's being developed, or a consensus document, just about, again, this palliative care integration for the entire spectrum, including heart disease patients and patients receiving mechanical circulatory support. In addition, not just the transplant societies, but the American Thoracic Society, the American College of Chest Physicians, the European Respiratory Society, the Canadian Thoracic Society, and then other societies, the Australians and the British, are also advocating for palliative care integration for patients with non-malignant lung disease. There are issues, and there are a few barriers with a transplant population, and that's this somewhat common feeling that the goals of transplant or mechanical circulatory support, if you're thinking about heart disease patients, are incompatible with palliative care. That one is focused on life prolongation, but palliative care is focused on symptom management and not necessarily prolonging life. And so I think that leads to a lot of sort of, non-referrals or fear of palliative care getting involved. I think some programs are worried about the impact on 1-year survival. So if palliative care is involved, or if patients, want less aggressive care, is that going to then impact their numbers? And certainly in the US, where the data and the metrics are tracked, and in Canada too, like that can become important. There's ongoing concern about opioid and benzodiazepine use and how that might impact a patient and their outcomes. There is an opioid epidemic, I think probably worldwide, certainly in Canada. There's lack of access to specialized palliative care services, and that's both from a clinician perspective. So there aren't necessarily specialized palliative care doctors or nurse practitioners or clinicians that are available in transplant programs, and they may not have access to therapeutics. I know that, we in Canada are very lucky with the range of opioids that we can prescribe to people, and that doesn't exist in many other places. And then there's this sort of interventional optimism bias, which really favors aggressive therapies over conservative approaches. So the idea that doing something, pushing more, I think this exists also in oncology, is always the better thing, and sort of pulling back and is not, I can mute that person. I have that power. Pulling back is potentially a problem. I have to balance this. I'm well aware, and it's like my two little people on my shoulder, with potentially like a bit of a therapeutic nihilism bias, which I think some of us in palliative care may adopt. So, which is that we're so used to seeing patients fail therapies that we may move sometimes more quickly to pulling back. And sometimes, especially when someone's being considered for transplant, being aggressive does make sense. But I do think that keeping both of these biases in mind is very, very important. So, the traditional model of palliative care would suggest, so this was where you would get life-prolonging care until you couldn't anymore, and then you could get end-of-life, then you'd move to end-of-life care, and that's when you'd get palliative care. And this basically would mean that you would have to wait, if someone's on a transplant list, until they were delisted or too sick for transplant in order to actually consult palliative care. But what my ideal is, and I've stolen this from the cardiology world, is to really, and what we're doing in Toronto, and a lot of programs I think in the US and around the world are starting to do, is really this more integrated model where palliative medicine, which is the purple line on the bottom, can be given in tandem with the orange, which is more disease-focused care, treatment modifying, more sort of like curative intent therapies and things like that. And so on the top in the red, is quality of life. You can think about it as lung function. You can think about it as ejection fraction if you're dealing with heart disease patients at the onset of symptoms. Quality of life is low, lung function is really low. They might have had their, ILD flare or something. Then you pile on therapy, get them started on their, they're getting their steroid boluses, they're getting started on their antifibrotics, and hopefully they stabilize for some time. But as they progress, they may need more, adjustment in their therapy. They may need more symptom management. The orange circle it's from cardiology. So the orange circle is where they're being considered for mechanical circulatory support or transplant. But in lungs, it could be when they're being considered for transplant, or, maybe when they're getting put on extracorporeal life support even. And then if they're a candidate for transplant, then they get transplanted. If they're not, that's when they would progress to end stage disease and end of life. And that's the point where really palliative measures would overtake the more disease modifying therapies. And then palliative care also can go on to support patients or families through bereavement after death. So how do we get to this more integrated approach? So I think there's a number of different models to get there. And I think different people are experimenting in different ways. So one is to build capacity for primary palliative care. And that is, incorporating symptom management, critical communication training in our subspecialty training programs beyond, so cardiology, respirology, this is respirology, or pulmonary medicine, critical care medicine, so that the teams themselves, the transplant teams, the respirologists can start at least to manage these symptoms, not be afraid of adding opioids. And that's happening. So I'm getting patients now referred to me where the respirologist has already started them on their opioid for their cough. And now it's either not working, or they just now want me to take over a little bit with that, or they've forgotten the laxative and now the patient's constipated, which is a problem. But there are ways to do that. And then also integrating comprehensive symptom management at routine respirology visits. And whether the respirologist or the pulmonary doctor has time to do that, or gets a palliative care clinician in their clinic to do it with them is, again, it depends on the models of care and probably funding structures. You could standardize palliative care referral, which Daphna is going to show you what they're doing at North York later on, but with trigger tools. So, every patient who meets some cutoff criteria will get referred, or just these are the people to think about. And I think I understand that that's also that's being worked on in Israel as well. And then there's other ones based on family request, recurrent or prolonged hospital admission. These are just some recommendations, or obviously when patients are transitioning to end of life care. And then finally, and I talked about it a bit, but embedding palliative care specialists within the transplant team. And what that does is we did a study over a decade ago about what the barriers were, and people felt that if they were referred to palliative care, there would be this sense of abandonment from their transplant team. But if it's routine practice and the palliative care team are part of the transplant team and everybody's working together, then that helps to mitigate against that as well. And what we've done in Toronto is we don't see them, we're not in the same clinic per se, but everybody who is referred for transplant assessment and is moving forward, whether they're going to be listed or not, is also referred automatically for palliative care consultation. And then whether the palliative care team continues to follow them, often we do follow them through their transplant listing process and maybe through their transplant. Usually we stop following them if they get transplanted. That depends on the patient and what's happening. It also makes it easier, usually, to refer, unfortunately, again, when these patients develop chronic lung allograft dysfunction post-transplant. So now I'm going to turn back to Asya and Daphna.
Okay, Rebecca, thank you for that amazing information. What we want to do now is all work together and work through Mr. ES and how we would manage all his symptoms, his physical, his psychosocial symptoms, and what would be the approach or the palliative care approach for this patient, whether or not before he's on the transplant list and during while he's waiting for transplant. So what we thought is we're going to bring Asya's experience in Canada to Israel. And so what we're going to ask is if you can use the chat function to raise your hand. Both I and Shirley are going to watch so that we can kind of give everyone a chance who wants to speak. If we're not seeing you, please put in the chat that your hand has been raised. We're going to kind of do it in order. If you guys have Any questions, please put in the chat, either in Hebrew or in English. Shirley's going to work with, read the Hebrew, I'll read the English, then we'll stop Asya every so often, just to make sure those questions are being addressed. All right, so I'm going to turn it over to Asya to moderate.
Okay, thank you both for this really comprehensive and practical overview of this patient. So yeah, let's talk about how we're going to manage this patient, Mr. ES, and his symptoms. First and foremost, his most debilitating symptom would be the cough. So I'd love to hear from people, how would you manage this patient for this symptoms? Yeah. So maybe we can start with our speakers, just to kind of get the sense. Shirley, how did you manage his cough? And then maybe people will feel more free to join.
First of all, I listed the drug that he had taken, saw what is the influence of a drug or other conditional period to is lung disease. So we had the esophagus barrette, so I make sure that he had Nexium or other PPI that can contribute to his cough, and especially in his sleep. And we took an anamnesia about how does he sleep, how many pills. And also I saw that he took an ACE inhibitor prior to the Lecropress that we changed. I thought that I had it, that everything was gonna be okay, but it didn't turn up. And also, I will put something that we're not gonna use in this discussion because I think it will take it oversized. He came to me to, like a lot of patients come to palliative care doctor and told me, you know what, I took from the cannabis of my daughter and it put me down to sleep very good and I didn't have any cough. Which I didn't know how to approach it. I didn't have a lot of data. I also asked Rebecca that she doesn't have a lot of data. And I don't want this discussion will sum up with the cannabis. We don't want to talk about it because we don't have a lot of data.
There is data. It doesn't work. The evidence is the evidence is that it doesn't work. There's data. It's negative. There's no improvement.
So I knew maybe it will help him a little bit in the sleeping, but it doesn't help him with his cough. So I knew that I have to take it another approach to see how will help him. So any kind of thought help me, guys.
So question to this group, if you're going to start opioids for cough, can you share how you are starting opioids?
So because the patient only had cough in the night, so it was very easy to me to start intermediate opioid. Will take us 4 to 6 hours. So I start oxycodone, which is the most common drug that we use because otherwise the Ormorph or MIR that we use is hard to find in the pharmacies in Israel. So I started with 0.5 ml, which is 1 milligram, which is very low dose. We doesn't use the doses we use to pain. So if we talking about cough or dyspnea, we use very lower doses. And so that's what I started with him, which can help him for a little bit, like 2 months.
Asya, I'm going to turn it to you because you're from Israel and recognize how you do things in Israel. But from what you've been seeing in Toronto, how would you start opioids now?
Well, actually, I've been joining Rebecca's clinic lately, and so that was really eye-opening. I think, treating malignant and non-malignant disease are so different in terms of like how you think about it, the dosage that you're allowing yourself to start with. So I think firstly, really optimizing the oxygen use and really taking a good history to like, when are you taking it? For example, we had a patient, he was like only taking like a puff of oxygen when he was going to do something, and he was like short of breath all the time. And so with this patient, you're not going to start opioids right away. You just want him to be like, to think that, you know, you need that oxygen, you have to use it. And then we'll start morphine, I think, you know, that like the smallest dose, 2.5 PRNs, and just to see if that helps him with the shortness of breath, with cough fits, and then go from there. I think that's my go-to. Yeah, go ahead.
Oh, no. Are you finished?
Yeah, I think Daphne wanted to say something.
No,
Oh.
I just, as you're responding, Rebecca, I just noticed there's a
I
question in the
saw the
chat.
chat. I saw the
Okay.
chat. But I was gonna, so just to pick up on, so, you know, just to pick up on what Asya's saying, like us, why are we talking about oxygen when we're talking about cough? Because we were talking, but it's amazing. I find there's actually a little bit of data about it I didn't show, but it's amazing how many patients will say, it depends, maybe not for Mr. ES, but it's amazing how many patients where the exercise is actually the trigger for the cough. And it's not, I don't think it's that well understood, but I sort of always think that it's like when you're breathing harder, that you're sort of triggering and stimulating those more proximal, receptors. And in that case, oxygen actually, it's not just treating the dyspnea, it's also treating the cough a little bit. And then they don't start that horrific coughing spasm that then sets them out completely. You know, to this patient, you know, I think Shirley, you were on the right track. A nighttime only cough in a patient with Barrett's, you know, he's got ILD, great, but it's very shocking to me that didn't have as much daytime cough. I would just try to really aggressively manage the Barrett's, not just, you know, about his PPI, but making sure he's not eating at nighttime, making sure he's sitting up, thinking about referral for like, does the Barrett's need like, you know, what's happening there? Thinking about a motility agent. We didn't mention that diarrhea was an issue for him, but if this guy eating small frequent meals, like if he's eating a big dinner and then he's going to bed, it's all going to be sitting there. If he's got slow motility in some way, that's going to make his cough worse. You know, the question in the chat, what about codeine? I don't know. I mean, I can answer that for sure, or I don't know if other people, if the Israelis want to answer that. We do use codeine, so but I can. Do you want me to? I'll give you. Well, since I'm already talking and unmuted, I'll just say that a lot of people are more comfortable with codeine than using morphine. Codeine is metabolized to morphine in your body, and 20% of the population, from what I've read, don't metabolize codeine appropriately. So they end up with a lot of side effects, a lot of nausea without the benefit. So that's why in palliative care, I find most of us don't love codeine. We have hydrocodone cough syrup and codeine syrups. And again, lots of people feel like it's safer. And I've had a few patients tell me they like it more than their morphine when I've tried to switch them. And if that's the case, fine. They can use it. Same side effects, same monitoring. But if it's not, if it doesn't work and they like the morphine better, that's what I would do.
So I want to ask you, you said, oh, somebody raised his hand. Daphne, it's you. Talk.
I have a question. I have to say, I have never used lidocaine. However, I have had patients in my clinic who are having an acute, severe coughing, and I'll give them their opioid, and it's just not breaking. And I'm actually curious about that. How much Rebecca, can you talk about how much lidocaine you put in what?
Yeah, it's usually like I have a protocol. I don't have it off by heart, but it's I can send it to you. It's basically like what you would do again before bronchoscopy is about 2 to 4 milliliters. There's nothing sort of like standardized per se of basically 2% lidocaine without epinephrine that you need a nebulizer. So you can't just do it and decide, hey, I'm going to do this today and send it to people. Like it involves a whole setup. And you probably also want the mouthpiece, which looks like the end of a saxophone or like a wind instrument as opposed to a face mask. Although I know my colleagues who are doing this at home are using face masks. And you just nebulize it till it's gone. So you're just, inhaling in and out with it. remembering that it can cause acute bronchoconstriction sometimes and can worsen cough at the beginning. So you could try to pre-medicate someone with a bronchodilator. Again, this might be the one time I would give an interstitial lung disease patient a puffer. And then it will numb their oropharynx. So you have to really counsel them, but it does help sort of just settle that cough.
Thanks.
Thank you. Sorry.
I have a question.
Yeah, go ahead.
Why not trying in this patient some neuromodulatory drugs, something like pregabalin, because it's, again, the cough is mainly at night and it's a little bit sedating.
We tried.
I'm sorry?
We tried.
You tried. You
We
tried. It didn't
tried.
help.
We
Okay,
tried.
so
After
it was the first line and then...
Yeah, it was before we tried the oxycodone. We tried pregabalin, and then we tried Lyrica, and it just numbed him, but it didn't work.
on the cough.
On the cough.
Yeah.
And the cough, and eventually, during his decrease of his lung function and his deterioration of the physical condition, he also had cough during the day. It's actually was the primary symptoms that make him stop his work.
Okay.
This thing and the thing that he couldn't travel anymore, which work is based on his traveling.
So what about if we give opioids and he also coughs during the day? So why not giving him a long-acting something like like Tolgin, maybe 5 milligrams or 10 milligrams twice daily? What do you think about this option?
We want to ask you guys in the audience if you had any experience with long-acting opioids. We will talk about thalidomide in a bit. We just want to focus. Gidon, tell us.
No, I raised the hand to ask a question after Adil's question is addressed.
I wanted to throw in Adir's question because you just asked about long-acting. Asya, there's a question in the chat. Adir says it's not uncommon to find patients on opioids with a cough, and then codeine is added to the mix. Is there any logic to it? So we've got two questions: adding codeine and long-acting. What did people think?
I also want to be mindful of the time, so we have just a couple minutes for that. Thank you.
Rebecca, do you want to answer those two questions?
When they're already on when they're already on a standard opioid like oxycodone or morphine, and then someone tries to put codeine on top because they just don't pay. I think, to me, I always laugh because I just think that someone's not necessarily looking to see what meds they're already on. It depends on I have one patient who uses a mix of morphine and codeine and swears that it's just helpful in different ways. I think that the codeine in that patient is probably a drop in the bucket compared to what he's already on. He's not sedated by it, so I let it slide. But generally, I try to stick to one type of opioid just to reduce the chance of toxicity and making a mess and running into trouble. That's that one. Yeah.
And long-acting and switching.
Oh, long-acting. So yeah. So I use long-acting. So I don't use long-acting for dyspnea per se, unless someone's clearly using it regularly, kind of every 4 hours, and that's what they're needing. And then my approach to long-acting is I would start a long-acting, and if their short-acting use doesn't change at all after their long-acting use, after they are on, I just stop the long-acting again. And if they get worse, maybe I'll add it back. But for cough, yes, long-acting I will use if they're using their short-acting again in a way that makes the long-acting justifies the use of a long-acting. I don't use Targan. We have it in Canada. I've never used it. We have a lot more access to different long-acting opioid preparations, I think, than in Israel. We have long-acting morphine. We have short and long-acting hydromorphone. We have long-acting oxycodone. So generally, I'm using long-acting morphine or long-acting hydromorphone in a 12-hour formula. And Gidon has a question also.
Yeah, these patients are usually long-term patients, let's say it works. Let's say it works excellent. And then do you have does this have a time limit or a decrease in effect? And what do you do then? Do you switch opioids? Does that help or something else?
Excellent question. If it's okay, can I answer? So I follow these patients. I think it's the other piece. So one is I follow these patients sometimes for years. And I start them on opioids, and I don't know that people were expecting that necessarily. So I also try not to exceed 30 milligram equivalents of morphine per day. Um, there was one population study in COPD patients that showed that it was correlation, it was retrospective. So I think that there were issues with that, but it showed that morphine in doses of over 30 milligrams was associated with increased mortality. I think it was confounded by indication. These patients were sicker, needing higher doses. But it gives me pause, and I also find diminishing returns with higher and higher doses. And when these people, it's like this, it's similar, and apologies to the respirologist, but it's similar to now these chronic cancer patients who are no longer dying of their cancer and having this chronic cancer pain for years and years. And what do we do with their opioids when we're following them for this long? So you could consider rotating for sure. You can up the dose a little bit. Thankfully, I find that most people don't need so much of a dose escalation. And then the other part that I just say, keep in the back of my mind, and it's how I counsel people from the start, is this is a really hard thing to treat. I'm not going to make your cough go away completely. We're trying to make it a little bit better. The only time I would really escalate is if they were really at end of life and they would accept the sedation and the other stuff that goes along with it. But sometimes, even as a palliative care doctor, I say, listen, this is what it is. And then we work on the other non-pharmacologic things, or then add, there was the question about the neuromodulators, and maybe the neuromodulators on their own didn't work, but maybe now at this point, adding a neuromodulator back or something else might help. And there was all these studies about these P2X3 antagonists, and there's defaxapine, I can't pronounce it, that was the P2X3. And then there was the NK1 receptor antagonist in cancer-related cough, but again, the evidence is not great. They're not available, so we don't have lots of other things. So I just counsel, try not to increase too much, and maybe those people will get transplant. Oh, I will also refer people sometimes, if you think it's multimodal. I don't know what the relationship is like with ENT, but sometimes patients have a lot of upper cough, and then I refer them for either Kenalog or Botox injections to their cords, not to the cords, but to the superior laryngeal nerve. They can get blocks there. So some of my patients with really horrific refractory cough, where you think there's a proximal component and they haven't responded to everything else, may benefit from ear, nose, and throat and some local thing.
Thank you. Shirley or Rebecca, can you go back to the slides? And then
Yeah. Somebody just asked about thalidomide. Did you use it?
No, I was putting an answer in the chat. You can't get access to it through Health Canada, and I've spoken, and to me, it's just not worth it. It's absolutely insane here. I've spoken to the head of the interstitial lung disease clinic. I think he tried about 5 years ago, and he's like, it's not worth it. So no, we don't use it. The study, and it's quoted in all the papers. It is exciting. It was a tiny study, so I think if it actually was used more widely, we might find it doesn't work so well, but who knows?
Okay, thank you. So we have just really 3 minutes to kind of wrap things up. So Daphne wanted to show us her referral criteria from New York.
So if you want to go to the next slide, just the next slide, so you'll see. I just wanted to share this with any of the pulmonologists here on the group, or any folks here in palliative care who are planning to start a clinic with your respirologist. So we got together with the cardiologist you'll see on your left side and the respirologist on the right side, and we developed trigger criteria together with the respirologist. So that there was a standard of when the respirologist or the cardiologist would refer to us. So you could take a picture. I'm happy to send it to you in case you want to start that. But then going back to Asya for the next slide, because she has and Shirley have exciting news to share. Can you, yeah.
אוקיי. אסיה, תגידי.
I'm going to say that. It's not even mine, but yeah, it's really, really exciting. So this is the draft version that Shirley and I know Dr. Nimrod were developing together with the Association of Respirology in Israel. So it's going to be published real soon. So the clinical criteria for referral for palliative care. So I think you can take a picture of that also, and we can also post that on our WhatsApp group. And you can continue also talking and discussing the things that were raised and we didn't even address, you know, with this patient. Yeah. Okay. So if you could change the slide. Where is the next slide? Okay.
Okay, so I will put it. Just a second.
Okay, great. Thank you. So thank you all for this really rich and thoughtful discussion. I want to thank Dr. Colman, Dr. Yanai for your excellent presentations and all your contributions today. Thank you everybody for participating, asking the questions. I want you to mark your calendars for February 22nd for our next Aderat Palliative meeting, where Dr. Daphne Grossman together with Yael Orion will be presenting. You're welcome to join our WhatsApp group where you're welcome to ask questions, share cases. There it is. Amazing. And this is the QR code for the WhatsApp group if you want to join and continue the discussion there. So thank you again, and we look forward to seeing you next time.
Thank you very much.
Thank you. Thank you to Rebecca and to Daphna, and thank you Askia and Adir was have the mind behind all of the things in Israel here. אני אגיד כמה דברים בעברית, דפנה וריבקה, אני יודעת שאתם מבינות. פתחנו, אנחנו והקנדים ביחד, הם עושים את זה בקנדה, אנחנו עושים את זה בישראל, פתחנו קהילה. אנחנו רוצים כן לחוות בינינו, אנחנו קהילה קטנה לא גדולה, אנחנו רוצים לחוות בינינו את הניסיון שיש לנו בסוף, הדאטה הוא לא הרבה, אנחנו ממציאים עם חוכמת ההמונים, אז מי שיכול לשתף, משהו עבד, משהו קרה עם מטופל, אז יש את הקבוצה שאסיה פתחה ואנחנו מזמינים אתכם להביא דברים לשם ודברים שאתם רוצים שאנחנו נדון עליהם, אנחנו פתוחים לכל ככה המלצות, אני אגיד שההמלצות שנמרוד דוקטור אסנת שטרייכמן ויעל מהאיגוד לרפואת משפחה כתבנו ביחד לאינטגרציה של טיפול תומך בריאות, אני מקווה שאוטוטו אריה יפרסמו את זה, זה צעד מאוד גדול עבורנו, אני מקווה שכמה שיותר פולמונולוגים יקפצו על העניין ויפנו אלינו, כי אנחנו פה לעשות שיתופי פעולה חשובים עבור המטופלים שלנו. תודה רבה לכולם, שיהיה שבוע טוב, שיחזור החטוף האחרון ושהכל יהיה מאחורינו.
תודה רבה.
אמן,
תודה
תודה.
רבה. ממש מהמם, תודה.
היה מצוין.